Factors affecting drug distribution. So distribution is a movement of drugs or any substance from the blood compartment into the tissue compartment. So blood compartment it is most water in nature, while tissue compartment it is lipidal in nature. So let us discuss the factors. First one is tissue permeability of drugs. So for a drug to get into the tissue compartment, it should be permeable into the tissues, and the tissues are always lipidal in nature. So the drug which is more lipid will be showing more permeability. See first one, physicochemical properties of the drug. So I already mentioned the drug is more lipid soluble. They will be getting more distributed from the blood compartment into the tissue compartment. Second, physiological barriers. So physiological barriers are all blood capillaries. The usual blood capillaries what we see in the peripheral body is having much intercellular spaces. They are having very loose junctions. There is a space between the endothelial cells so that the substance can easily pass between the cells. Intercellular passage. So any water soluble substance can also move from the blood compartment easily through the usual capillaries. But physiological barriers, the capillaries will be having tight intercellular junctions. There won't be any space between the cells in the capillaries. They will be having a very tight intercellular junctions like blood-brain barrier, tight intercellular junctions, and again covered with astrocytes, as you know. So the drugs or any substance, if it wants to cross the physiological barrier, it should be more lipid soluble. Then only it will be able to pass through the cells. That is intracellular passage. So physiological barriers, example like blood-brain barrier, which will restrict the entry of drug from the blood into the brain. So if a drug wants to enter from the blood into the brain, it should be more lipid soluble. Blood placental barrier, which will restrict the entry of drug from the mother blood circulation into the fetal circulation. And blood testis barrier, which will prevent entry of drug or any substance from the blood into the testis and prevent influence on spermatogenesis. Second factor, organ or tissue size and perfusion rate. If the organ size is more, the distribution will be more compared to other areas of the body. And perfusion rate, if the blood flow to a particular organ is more, perfusion, that means the amount of blood flow into a particular organ. If the blood flow to the particular organ is more, that is perfusion rate is more, the more amount of the drug will be delivered to that particular tissue. Third one, binding of the drug to extravascular tissue protein. There are certain drugs which shows affinity for certain tissue proteins. For example, chloroquine. It shows more affinity for the retinal proteins. So they may get deposited in the retina. So that will increase the distribution of the drug from the blood compartment to the tissue compartment. Binding of the drug to plasma proteins. There are some drugs which will bound to plasma proteins like albumin, globulin, alpha-1 acidic glycoprotein, lipoproteins, etc. So if the drug is bound to plasma protein, they will become more water soluble and they will be larger in size, and that make the drug less permeable through the blood vessels, or even the usual capillaries will not be permeable for the such drugs which are bound to plasma protein. So plasma protein binding of a drug or a drug which is bound to plasma protein will be showing less distribution into the tissues. This plasma protein binding, it is of more clinical importance. So I am discussing that. What is the significance of plasma protein binding? Usually the drugs which are bound to plasma protein will be pharmacokinetically and dynamically inert. That means they are not metabolized, or they are not excreted, or they are not distributed. They remain within the blood circulation. That is, they are pharmacokinetically inert. Pharmacodynamically inert means if it is not able to enter into the tissue compartment, it is not able to produce any action in our body. So a drug which is bound to plasma protein will be pharmacokinetically as well as pharmacodynamically inert. The drug which is bound to plasma protein, they will act as a depot. because only the free drugs which are present in the blood is able to enter into the tissue compartment, and the drug which is bound to plasma protein will remain in the blood circulation. So this will maintain a equilibrium, the free drug and the drug bound to plasma protein. When the free drug enters into tissue compartment, the concentration of free drug in the blood reduces. So the drug bound to plasma protein will be released, and the free drug and plasma protein bound drug equilibrium will be maintained. Again, the free drug will move into the tissue compartment, and again the drug which is bound to plasma protein will be released, and the free drug concentration will be maintained. So that act as a depot. They slowly release the drug into the circulation from the plasma protein bound state. They act as vehicle, especially lipoproteins. They help highly lipid soluble drugs to be soluble in the blood. Any drug which is highly lipid soluble, they are not soluble in the blood, but they will be made soluble by binding to lipoproteins and made soluble in the blood so that it can circulate throughout the body. They prevent accumulation of the drug into the tissue compartment. Repeat, prevent accumulation of the drug into the tissue compartment. Why it is important? Because accumulation of the drug into the tissue compartment will lead to toxicity, because large amount of drug will be accumulating in a particular organ. It can exaggerate the response and can lead to toxicity. So the drug which is bound to plasma protein will be slowly releasing into the blood to the free form and only slowly reaching the tissue. So that will reduce the accumulation of the drug in the tissue compartment. Favor uniform distribution throughout the body. As I already mentioned, the drug which is bound to plasma protein is not available for transfer from the blood into the tissue compartment. So it will be traveling throughout the systemic circulation, slowly releasing the free drug from the plasma protein bound state, and the free drug will be slowly distributed uniformly into the various tissue compartments in the body. Displacement, interaction and toxicity. That is another important clinical significance of plasma protein binding. I will discuss that later. So as you can see here, example, warfarin is displayed by phenylbutazone indomethacin sulfate drugs. Warfarin, it is an anticoagulant and it is highly bound to plasma protein. Say 99% of warfarin which is administered will be bound to plasma protein, and only 1% will be available in the free form in the systemic circulation, which will be effective or preventing the blood coagulation. And phenylbutazone indomethacin sulfate drugs, they can displace because they also bind to the same binding site of warfarin in the albumin and displace warfarin from the binding site, and it will increase or it will suddenly increase the plasma level of warfarin. So that will exaggerate the response of warfarin, preventing the blood coagulation, leading to the serious side effects like bleeding, bleeding from the nose, epistaxis or ecchymosis or hematuria. I hope it is clear for you. Displacement interaction can lead to toxicity. Understand, it is applicable only for the drugs which are highly bound to plasma protein. An example is warfarin. It is highly bound to plasma protein. 99% of the drug administered will be bound to plasma protein, and only 1% of the warfarin will be in the free form in the blood, preventing blood coagulation. And if a drug like phenylbutazone or indomethacin or sulfate drugs, if it is administered along with the warfarin, it may displace warfarin from the plasma protein binding site. So instead of 1% in the free form in the circulation, it may increase the availability of warfarin in the blood to a larger extent. So that will lead to exaggerated response, increase influence on blood coagulation, prevents blood coagulation, leading to bleeding from the nose, what we call epistaxis, bleeding under the skin, ecchymosis, and hematuria, blood in the urine. This is tissue protein binding of drugs. Certain drugs binds to tissue protein, already mentioned. tissue protein binding will increase the distribution of the drug. So what is the clinical significance of that? First one, it causes toxicity. Already mentioned, increased accumulation of the drug in a particular organ in the active form can lead to increased or exaggerated response, which leads to toxicity. Example, already you have seen chloroquine, high affinity for the retinal protein, so they tends to accumulate in the retinal protein, leading to bull's eye maculopathy. Second, it can be used for diagnosis. So certain drugs or chemicals can be targeted to a particular tissues. You can see here chlorine atom of the chloroquine drug. If it is replaced with the radioactive iodine 131, it can be utilized to visualize melanoma of the eye. Why? Because chloroquine shows more affinity for the retinal protein. So chloroquine will take radioactive iodine 131, which is attached to the chloroquine to the retinal protein, and the radioactivity can be measured and we can visualize melanoma of the eye. Therapy as well as drug targeting. This is a great advantage of tissue protein binding, because the drug targeting is a problem in all the treatment of various diseases. So especially in cancer treatment, if you are able to deliver the drug exactly into the tissue which shows malignancy, we can avoid so much of side effects and we can get so much of beneficial effect. So that drug targeting is nowadays all the drug manufacturers are looking for targeting the drug directly into the organ where we want the beneficial effect. See the example, nitrogen mustard. It is an anti-cancer drug used for treating malignancy. If it is attached to estradiol, it's a estrogen, natural estrogen, it can directly deliver to the prostate and can be used for treating prostate cancer without producing much side effects. Redistribution. So usually pharmacokinetic, it was only ADME, absorption, distribution, metabolism and excretion. But coming to redistribution, it is a process which is happening between distribution and metabolism. Usual process, after the distribution of the drug in the tissue compartment, it is supposed to get again distributed back to the systemic circulation and taken to the liver, metabolized or taken directly into the kidney and excreted from the body. But there may sometimes the drug get redistributed from one tissue where it is distributed initially to another tissue before they transfer back to the blood, what we call redistribution. See the definition: distribution of a drug from its primary site which show high blood flow, primary site of distribution to the secondary site with either more affinity or solubility for the drug. I repeat, distribution of a drug from primary site of distribution to the secondary site, and secondary site will be showing more affinity or solubility for the drug. See the example, thiopentone. It is a general anesthetic. So all the general anesthetics will produce CNS depression. So for producing CNS depression, the drug should be able to cross blood-brain barrier and reach the CNS, producing CNS depression, resulting in general anesthesia. So the primary site of thiopentone is central nervous system, because it is highly perfused. The perfusion rate to the brain is very high and the drug is highly lipid soluble. So it can easily cross the blood-brain barrier and can reach the CNS. But the secondary site of distribution is adipose tissue. The secondary site of distribution is adipose tissue. Why? Because it is having high lipid solubility, and adipose tissue, as you know, it is lipid rich or it's highly lipodal in nature. It stores the fat, so it can get dissolved in the adipose tissue. See the figure. It's a brain, and you can see the blood-brain barrier as a systemic circulation, and when thiopentone is administered by IV route, it can easily cross the blood-brain barrier. Why? Because of high lipid solubility, it can cross blood-brain barrier, and blood flow is high to brain, so it can fast at a higher rate. It can reach the blood-brain barrier and produces depression, leading to general anesthesia. But the general anesthesia will be produced only for a few minutes. The general anesthesia is maintained only for 8 minutes in case of thiopentone. The reason is redistribution. The drug is rapidly redistributed from the brain into the adipose tissue. So the drug is no longer available in the brain. So the depression in the brain is recovered, and patient will recover within 8 minutes from the general anesthesia after giving thiopentone. This is one reason why thiopentone is a very short acting or ultra short acting general anesthetic. Drug metabolism or biotransformation. So what all drugs which is absorbed will be distributed into the various tissues or may get redistributed, but finally it has to be metabolized. It will be taken by the blood into the liver for the metabolism. All drugs are poison, but all poisons are not drugs. So drugs are all poison. It can lead to toxicity. So it has to be detoxified and removed from the blood after the action is over, preventing the accumulation of the drug which can lead to toxicity. So biotransformation is the specific term used for the metabolism of the drug. So when you consider the metabolism of the drug, the term used will be biotransformation of the drug, and it is defined as enzyme catalyzed chemical transformation of the drugs. And the aim of biotransformation is to make the drug more water soluble so that it can be easily excreted by the kidney. So kidney, as you know, urine, it is all water. So if the drug is made more water soluble, it will be easily excreting through the kidney without distributing to the tissue compartment again. Fate of biotransformation. After the metabolism or after the biotransformation, the drug can converted to different forms. That is the fate of biotransformation. Let us see one by one. So first one, phenobarbital and hydroxyphenobarbital are given in the bracket A and IA. A is the active form, IA is the inactive form. So the first biotransformation, the outcome will be the conversion of an active form of a drug to an inactive form of a drug. Kindly note down like this. Fate of biotransformation. First fate is conversion from active form to inactive form. Example, phenobarbital, which is active form, to hydroxyphenobarbital, which is the inactive form. The second fate is conversion of the drug from active form to again another active form. Example is diazepam, which is active, to oxazepam, which is again active. So advantage of such a conversion is the duration of action of the drug will be more. Even the drug is taken back to the liver for metabolism, it generates an active form again, which is again absorbed back into the systemic circulation, again reaching the site of action, again producing the action. So the duration of action will be more. The third one is inactive form to active form. Next fate, inactive form to active form. I hope you remember the prodrug. It is a conversion of inactive form of a drug to an active form. So levodopa, L-dopa, already we mentioned L-dopa as an example for prodrug. So L-dopa is the inactive form. It is converted to dopamine, the active form within the body. And third one, active form to a toxic metabolite. The T in the bracket mentioned the toxic metabolite. Classical example is paracetamol. The paracetamol, it is metabolized in the liver to a toxic metabolite, that is N-acetyl para benzoquinone imine. So